Sure, yeah, let's get cracking.
Right. Okay, so orthopedics and rheumatology is what we are here to talk about. I'm going to take orthopedics, Anusha's taking rheumatology, not surprisingly. And what we will be going through is the most important topics. At the end, we'll summarize some of the less likely things to come up, go through them a bit. If anybody has any questions about them, we can go through those as well. Anusha's already gone through how we'll approach the question side of things. So we shall get started. So first thing is orthopedics. So what I will go through individually with all of you is, first off, the principles of fracture management, the always brought up fractured neck of femur, then scaphoid fractures, ankle fractures, talk a bit about the limping child and neuropathies found on the upper and lower limb. I've got a list of miscellaneous topics at the end, which I will whiz my way through so that Anush can start with rheumatology, because there is more to that. Orthopedics, to be fair, is quite straightforward. There's the problem with it, I guess, is there is more content rather than things to understand. Not talking about the specialty itself. I imagine the specialty is quite hard, but for what you need to know, not too bad. Okay, so starting off, principles of fracture management. This is the first point where we make things interactive. What are the principles of fracture management? So, as Anush is instructed, if anybody wishes to answer, if they could just post the letter A in the chat, and we shall pick somebody to answer.
Or we'll just pick someone random that we know has done Mod B.
Do you want to do that?
As in, if no one volunteers, we'll do that.
We have William. William, unmute yourself and inform us of the principles of fracture management.
You're muted.
Reduce, stabilize, and rehabilitate. Is that it?
Wonderful. Yeah. So reducing, stabilizing, and rehabilitating. At the start, what is always mentioned is resuscitating. So obviously, if your patient comes in with a fracture, but they've been stabbed 20 times in the abdomen by a llama, then you will want to stabilize that first and make sure that, you know, you've got control of the bleeding, IV fluids, etc., etc., etc. Then you can start worrying about the actual orthopedic side of things. So as William said, the first thing you want to do is reduce it. Having a bone where it's not supposed to be is obviously problematic. It can obstruct structures, impinge on nerves, block blood vessels, and lead to a hell of a lot of complications. So you will want to move it back. Because of all the things that surround bones, obviously you want to check the neurovascular status before and after. Good example of this, for example, is a dislocation of the shoulder. You want to check axillary nerve function with the whole can they feel over the regimental patch beforehand. Then once you've reduced it, you want to check that you haven't impinged on the axillary nerve, so you want to check it again afterwards. Retain applies to fractures rather than things like dislocation and so on. If there is a significant fracture, you will want to hold it in position mechanically, usually invasively. For soft tissue injuries, for example, or dislocations, usually it's sufficient using things like slings, splints, plaster casts. But if something is broken, for example, the shaft of a long bone, you are probably going to want to open the person up and stick a screw inside their bone. That's what internal fixation is. So, or if open repair, internal fixation, the open bit is because you are cutting a person open. The internal fixation bit is because you are fixing the bone internally. Whereas external fixation, used more commonly for soft tissue injuries and things like open fractures. If somebody's come in and their tibia is sticking through their leg, your priority is probably not to put it back. Your priority is clean the area, give them antibiotics, debride. Once that's all sorted, then you can deal with fixation, but stabilizing the wound. So that's what's external repair, and then you can internally fixate later on. So that's the basis on which orthopedic surgery is built, and dealing with major physical trauma. Obviously, after that, as soon as a person is relatively stable, you want to get them moving again. This is, for example, why people aren't encouraged to stay in bed with back pain or to stay in bed 2 weeks after a hip replacement. You want to get people up, moving as quickly as possible. If you lay in bed for 2 weeks, then things atrophy, nerves forget what they're doing. You will probably not be as great at walking as you were 2 weeks prior. So elongated bed rest isn't encouraged in orthopedics unless they have literally broken every bone in their body and can't actually move. So we'll go through this bit really quickly. Just a useful thing to know. If it's an upper limb fracture, it usually takes about 6 weeks to heal. Lower limb is double that, 12. So about 3 months for a lower limb fracture to heal. Oh, that's a quarter of a year. That's a long time. But moving on to the first big thing. So this is hip fractures. There's a way of approaching this. Well, there's a way of approaching everything, I guess, in surgery to make it sort of systematic, but particularly to hip fractures, you can divide them across particular lines. Does anybody know how to start off dividing hip fractures? So in terms of a classification which would influence your management, what might you start off with? Again, if somebody can... Rose, unmute yourself and let us know about how to classify hip fractures, please.
Oh yeah, is it intracapsular and extracapsular first?
Perfect, yeah. And then in what way does that determine how you want to manage the fracture? Oh, no.
It's like it's something to do with the screws you use. I can't remember though.
Oh, yeah, fair point. Yeah, so it does affect the management. So the capsule of the hip joint is an important division for a start. So like Rose said, extracapsular is your first thing. If it's outside of the capsule, it is significantly less worrying. Then you will think about, is it between the trochanters? Anytime you see in an exam question something talking about intertrochanteric fracture, you throw dynamic hip screws at them. Doesn't matter what else there is. If you see intertrochanteric fracture, dynamic hip screw. That's your answer. Doesn't matter. Unless you become an orthopedic surgeon, this does not matter. For the next 4 years, you are going to go with a dynamic hip screw, which the slide has just proved my point. If it's a subtrochanteric fracture, which means below the trochanters, well, the greater trochanter, the lesser trochanter, the line between those, if the fracture's there, you use dynamic hip screw. If it's underneath that, you use a nail. You use an intramedullary nail, which goes through the medulla of the femur, which is where the name comes from. As for intracapsular, that's the bit I'm not a surgeon, so I don't really worry about it, but that's the bit which orthopedic surgeons worry a bit more about. So that can in itself be divided as well in terms of the Garden scale. Garden scale's annoying. I hate it. Know about it. Easiest way I think to remember is if it's 1 and 2, not too worrying. If it's 3 and 4, more worrying. What it basically describes is how bad the fracture is. From 1, which is it's a bit of a fracture, to 4, which is shit, the head of the femur has snapped off the rest of the femur. This is kind of bad. So if it's undisplaced, you can again use screws. But if it's displaced, that's when it's a larger operation. For SBAs, the bit that you want to care about when it gets to this point is how old is the person and what's their functional status. I'll talk a bit later about the importance of functional status, but if it's a person with an intracapsular fracture of their hip who is pretty immobile, you want a hemiarthroplasty. Arthroplasty is just a fancy word for replacing a joint, hemi being replacing half of the joint. The hip joint is made up of the acetabulum on the pelvis and it's made up of the pelvis and the femur. Hemiarthroplasty is just replacing the femur side of it, as opposed to a total hip replacement. If they can't move, you go for that. It's an easier operation with less risks. If they can, you go the total hip replacement. If it is a very, very unfortunate young person, like one of us has been in a high impact road accident, you can go for cannulated screws as well. But generally, if they're a mobile older person who tend to get the hip fractures, you can do a total hip replacement. If they're immobile, go for the hemiarthroplasty. That's your classic SBA material. Right. So the next question I pose to you all is, why do we need to replace displaced hip fractures? Yes, thank you, Anush. Hip fractures are really important. Yeah, so anyone want to answer? Why is it urgent to replace a displaced hip fracture? Thank you, Prina. Thank you. Yeah, okay. So people on the chat have been saying AVN, which stands for arteriovenous something. No, it stands for avascular necrosis. So there are several places throughout the skeletal system where, annoyingly, instead of the blood supply going from proximal to distal, it warps around. Joe has left the conversation, clearly does not appreciate my humor. It warps around backwards. So the problem is, if you receive a fracture further down, blood supply can't carry on and supply more distal areas. This is the case in the femur. If you have a displaced fracture within the capsule, you get in the way. Well, blood supply to the capsule is completely obstructed. The bone will die, and that person will probably not be able to walk again. This is why we need to deal with it as quickly as possible. Trauma is probably the biggest cause of the hip, but you do need to worry about other things. Steroids is a really, really big one for people who are on long-term medication, for example. It increases risk of osteoporosis as well. Does plenty of things to bone. Alcohol abuse, also a problem. Thrombosis, less common. You see it in Perth disease, which is a pediatric hip condition, which we'll glance on a bit later on. But avascular necrosis, if anybody ever asks you, why is it important to replace a hip as quickly as possible? It's because if you don't, you interrupt the blood supply. The head of the femur will just die. This is a problem at several parts of the body, but the hip's probably the most drastic one. Right. Something is broken here. Please spot it. Someone tell me where the problem is. You can just type it out, actually. Yep. Thank you, Alexis. The right femur is snapped. That is a displaced fracture. It's not an open fracture because it's not piercing through the skin, but we can't fully see that. Based on what we've talked about on the slide before the last one in terms of management, what would be the treatment for this fracture? So again, if somebody wants to type that out, or if they just want to unmute themselves and shout it out. Perfect. Thanks, Claudia. So it's intramedullary nail because it's a subtrochanteric fracture. So I don't know if my cursor comes up, but you've got your trochanters here. It's underneath the trochanters, so it's an IM nail. This is the kind of thing that happens during skiing accidents, for example, or really bad road accidents. Here, does anybody? Well, there is a massive arrow, so I'm not going to bother with that. But this is an example of an intracapsular fracture. So it's fracture where the arrow is pointing. You can see that the bone is essentially separated. This also is quite a bad fracture because if you pay attention, the bit that the femur is connected to is actually in front. Well, sorry, the distal part of the femur is actually in front of the acetabulum. So this is also completely snapped off. So this is a Garden 4 hip fracture. This would, depending on the mobility, need either a hemiarthroplasty or a full hip replacement. X-rays like this are favorite SBA material for the orthopedics things. So just get used to what they look like. Usually if something is broken, you'll be able to spot it. But the best tip that I think we could give you is, if you're struggling to find something, follow the lines of the cortex of the bone. So just follow outside, and if you see anything, if you see a breach, that's where your problem is. Okay, that's hip. That's all you need to know about hip fractures. Summarized as AVN, bad, replace immediately if it's intracapsular, and intervention depends on where the fracture is and the status of the person. Can you explain to tell which way it has displaced? Yeah, sure. So can I just check, is my cursor coming up? Okay,
It's not coming up.
Okay, it's not. That's fine. Okay, so valgus and varus is a rather annoying classification because it actually varies. It varies at the different joints. So at the knee, for example, it's different than to what it is at the elbow. But I think the gist of it is that it's usually if it's a lateral displacement, that's varus, and a more medial displacement is valgus. So, for example, in the slide that I'm on at the moment, that is a varus displacement of the right hip. Displaced is, yeah, if it's out of its position as this femur is, that's displaced. And in this one, that's a valgus one. So if you can see, that fragment has come medially. So the distal fragment of the femur has come medially over the acetabulum. So this is valgus displacement. But varus lateral, valgus medial. Trying to remember a way to remember that for you guys. But I'll probably remember something during rheumatology when Anusha's talking about that, and I'll just post it in the chat.
Wait, just one thing. So
yes,
there is a really good, if you go back a slide.
Yes.
If you're worried about whether or not a fracture is displaced, there's a really useful X-ray sign. Does anyone know what that is? Type it in the chat if you know what it's called. Yes, Shenton's line.
Wonderful.
So if you, I mean, you can, I'll post a picture in the chat, but Shenton's line is basically the normal anatomical arrangement of the hip joint, and you can see a nice curve. If that's displaced, then you're worried about a displaced fracture. I'll put a photo in the chat.
Oh yeah, Shenton's line, it's handy. What have I done? Sorry. So, scaphoid fractures, again, for considering how not too common they are, they come up a lot in exams. Again, same principle as the intracapsular hip fractures. Because there's retrograde supply to the scaphoid bone, because the blood vessels go up distally but then loop back proximally. If there's a fracture of the scaphoid, you are at risk of avascular necrosis, and again, the bone will just die, and that will lead to a permanent defect. The most common mechanism of injury, which is actually quite a common mechanism of injury for a lot of the upper limb fractures, is fouche, which is a fall on outstretched hand. So somebody trips on a slippery ground or something, and they fall like that. The impact zone's usually around here. Your scaphoid's sitting around here. It takes most of the impact. As a result, it's the most likely one of the carpal bones to fracture. So you have somebody and you are, what might somebody complain of that would make you potentially worried that they have a scaphoid fracture? Because a lot of people will fall on an outstretched hand, but so if somebody wants to just put the letter A, and then once I've seen that, yeah, so AVN is what you're worried about, but
symptom. What symptom?
Symptoms. Yeah, exactly. What symptoms?
Yeah.
Okay. Yep. Thanks, Bruno. So pain in the anatomical snuff box. For anyone who's not sure where the snuff box is, it's this little bit here. People used to use it for cocaine and tobacco. People don't tend to use it for cocaine anymore. Diabetic ketoacidosis, I'm going to ignore that. But yeah, so those are the symptoms you worry about. In terms of signs, there are things like if you find an effusion around there and tenderness off the snuff box as well. What about investigations? Fatty liver disease, wonderful. Investigations. So if you're suspecting a scaphoid fracture, what investigations will you want to do? Yep, perfect. So you want X-rays, and what I was about to ask, which was if there is no fracture, are you fine? But Sarah has said it won't show up immediately, which is, you guys are on it. Yeah, so if a fracture isn't there, you can't rule out a scaphoid fracture. The scaphoid is rather irritating in that, being a small, weirdly shaped bone, fractures don't come up immediately. So if you don't see something there, what are you going to have to do? Let me see if anyone's already said that. So people mentioned one. Have they already said it?
Yeah.
Has someone mentioned fracture clinic?
No, but
Yeah, so you will want to see them in a fracture clinic. Ideally, in 6 weeks. Some people do it in. I think the majority of cases is done within 2 weeks, because it can take, like Ellie's. Well, no, hang on, sorry. Christy has said, I thought it's 10 days. Usually, it can take around 10 to 14 for the fracture to make itself visible. So usually, it's about seeing the fracture clinic about 14 days after the X-rays are taken again. Usually, that's when the fracture is confirmed. If there is a really high index of suspicion, but you're still not seeing anything, the definitive is an MRI, because you can get a multi-level view. But usually it's a clinical diagnosis that's confirmed by X-ray, and it's relatively straightforward in that you splint it, and usually that's fine. However, if it is complicated, then you're looking at open repair and internal fixation. You don't want to miss a scaphoid fracture. They do get mixed. They do get missed, unfortunately. And what can happen then is you will get malunion of the scaphoid or complete non-union, which will lead to defects around the thumb. And if your thumb isn't working, well, it's very, very debilitating, as I'm sure you can imagine. So yes, if there's a fracture, you cast it for 6 weeks and you see them in the fracture clinic 2 weeks later. Those are guidelines, at least for our trusts or the hospitals that we're at. Ankle fractures. Right, these are actually really, really common, but don't get a lot of attention. So, as it says on the slides, they are the commonest lower limb fracture, and it doesn't need a lot of damage to actually happen. So any sort of rotational, it doesn't take much more than twisting your ankle. Any low energy rotational force can cause you to fracture your ankle. What is the name of the classification system for ankle fractures, which is actually really, really useful? Well, sorry, what's the name for the classification system? Okay, so Ankita has said Weber. Yes, perfect. Weber is right. William has said Ottawa. Ottawa is going to be the next question. So Ottawa is the rules for when you'd want to do an X-ray, whereas the diagram on the right with ABC is the Weber classification of ankle fractures. So usually if somebody comes in with an ankle injury, you're not going to X-ray them. However, if they have tenderness over either of the malleoli, or if they can't wait there for 4 steps, then you want to X-ray them. And you only need one of those. So looking at the diagram for the Weber classification, it's a bit confusing initially, but essentially if you look at where the tibia and fibula meet, and that sort of red joint there, that's the tibulofibular joint. If the fracture is below that, as is the case in A, it doesn't really affect the stability of the joint at all. So that's usually fine. In fact, those people, you can put them in a cast boot and send them home. They'll be okay. C on the other end is the most severe. As you can see, the fracture is above the joint and the joint itself is completely disturbed. This is a very unstable fracture. This needs to be operated on. Would you be able to load bear after reduction? So with A, if it's put in what's called a moon boot, yes, you can. If it's If it's casted, then usually they're on crutches. If they've had an operation, then they don't weight bear until I think it's usually at least 6 weeks until they'd have to weight bear. But yeah, B's in the middle. That's more of a clinical decision. Sometimes the joint's disrupted, sometimes it isn't, but you have to decide on the basis of how stable does the fracture look. So it's on the spectrum, which is the less severe cases can be put in a moon boot or a cast. More severe cases, you're going to have to operate on them. You do want to reduce them as quickly as possible, though, because, as I'm sure you know, there are a lot of vascular structures around the malleoli, and if you don't reduce it, then you can put pressure on them as well as the skin, and necrosis is bad. But yeah, those are ankle fractures. Don't come up too often in exams, but you will see them a hell of a lot if you are in A&E, which most of you will do a foundation job in. Compartment syndrome. This is the orthopedic emergency that you do not want to miss at all. So, what is compartment syndrome? Apart from being limb and life-threatening, as this diagram oh so dramatically points out. Do we have to know the ankle exam for OSCEs? Yes. Annoyingly, yes.
Does someone want to volunteer to give us a summary of compartment syndrome?
Perfect, yes. So we've got Melissa and Alexis. So eloquently put as loss of blood supply to structures because they got squished, and Melissa has put it as increased pressure in a compartment of the lower limb. And Ankit has said 6 Ps, which is acute limb ischemia, so stop trolling, Ankit, please. Yeah, so compartment syndrome, if you happen to remember second year Dean and Peggington elaborating on how the limbs are divided into fascial compartments, because this fascia is quite stiff, if pressure goes up in this compartment, it can't be disseminated anywhere else, so it just keeps on going up and up and up. If this pressure exceeds the perfusion pressure in this compartment, you lose blood supply because the vessels are getting squished, and as a result, you're at risk of losing that limb. What makes you worried that somebody might have compartment syndrome? Perfect. Pain out of proportion is a big one. So people are in excruciating pain, but you can't figure out a particular reason why. Is there swelling and erythema, but not usually the first signs. Analgesia is not working. Loss of pulses, yeah, good point. It's sometimes not there. In fact, a lot of the times it isn't. So you can't rule out compartment syndrome just because pulses are there. So a lot of these are poikilothermia and so on, and loss of pulses tend to be quite late signs. The earlier ones are things like analgesia is not working, excruciating pain. Those are symptoms. What's a sign? I'll get to your question in a second, Alexis. What's one of the signs of compartment syndrome? If you ask a patient to do something which makes the pain a hell of a lot worse for them. Perfect, yeah. So stretching. So any form of stretching, passive stretching, so you don't do it, the patient does it. If you ask them to point their toe upward, for example, that makes the pain a lot worse. So that's a really, really useful sign. Alexis asked, do you get redness or paleness in compartment syndrome? Those will be later signs. So paleness is going to be a really late sign and a really, really bad sign. So you're the F1 on the orthopedics ward and you think somebody's got compartment syndrome. What are you going to do?
Too early for amputation.
Yep. So call for help is reasonable. Okay. Yeah. Perfect. So fasciotomy is the definitive treatment. Rose is I hope I'm saying your name right. I'm sorry. Yeah, so Issy and Rose have made the very good point, which is the first thing you do after calling for help and so on is usually on any surgical ward, particularly the orthopedic ones, there is a kit. In fact, with any post-operative patient for orthopedics, there should be a kit by their bedside which enables you to split the cast or whatever dressing's been put on. That's the first thing you want to do. You want to remove the cast, then they will need to get to surgery as fast as possible in order to have a fasciotomy, in order to release the pressure and decompress the compartment. Perfect. Are post-op patients at higher risk of compartment syndrome? Yeah, and in fact, there's particular operations which are the highest risk. Does anybody know which two are the ones we particularly worry about?
No, go on.
Oh, video mal. So, perfect. Yeah. So, okay. Oh, structures. You mentioned posterior tibial, so I'll go with that. Any operation on the tibia is something is a patient you want to monitor for potential compartment syndrome, and any operation on the humerus, so after a supracondylar fracture, that's something you want to monitor as well. Those are the bones when operated on are most likely to cause soft tissue swelling and then lead to compartment syndrome. So, yet to answer your question, Ritika, usually compartment syndrome mostly happens in post-operative patients in those operations. You see it sometimes in other circumstances, like in burns patients, but usually when you worry about compartment syndrome, it's in post-surgical patients. And the thing to remember, it's a clinical diagnosis. You do not bother with taking them to an X-ray or measuring the pressure in their legs or so on, which is apparently what the formal diagnosis is based on. If you think that's the case, you split the cast, you take them to surgery. Okay, upper limb neuropathies. So these to do with the main nerves in your upper limb. So obviously you've got your 5 branches of terminal branches of your brachial plexus. We don't really care about the musculocutaneous branch because it doesn't get damaged that often. It's actually pretty impressive to damage your musculocutaneous branch. You have to sort of get stabbed the anterior part of your upper arm, which is impressive. But actually, oops, my bad. So yeah, we're talking about the axillary, the ulnar, the radial, and the median nerve. Main cause of an axillary nerve palsy. What we got? Perfect. Yeah. So shoulder dislocation. Breast cancer surgery is more commonly associated with the long thoracic nerve, but can also do it. Dislocation is the biggest, so particularly anterior-inferior dislocation of the shoulder is the biggest cause of axillary nerve palsy. And based on what the axillary nerve does, so the axillary nerve is both a sensory and a motor nerve, what are the two things that you look out for if you suspect an axillary nerve palsy? One being sensory, one being motor. Perfect. So regimental patch and wasting of deltoid. Very nice. Yep. So the regimental patch, which is your area here, is supplied by the axillary nerve. Loss of sensation there is highly, well, points to axillary nerve palsy, and wasting of the deltoid, which will take a while. So usually the thing that will come across sooner is weakness of the deltoid muscle. If you remember, when you're abducting your arm, deltoid takes over from about 30 degrees. So if they can start off the abduction of supraspinatus but can't carry it on, do we need to know nerve roots for year 4?
Yes.
I'd say yes. I'd definitely say yes. Know your nerve roots for year 4 because it will. It's come up for us. It's come up for years before us. But yeah, so that's axillary. Moving on to radial. What causes radial nerve palsies. Yeah, perfect. So midshaft fractures, the radial nerve runs in the spiral groove of the humerus. You fracture the middle of your humerus, you will get a radial nerve palsy. Since the radial nerve supplies basically all of the extensor surface, common sense says that you will lose sensation on the back of your arm and your wrist will go floppy, which is what you're looking out for. So radial nerve, usually quite obvious one. If they show a picture of a patient with this, radial nerve palsy. If they tell you you've lost sensation on the back of their hand, radial nerve palsy. There are several other causes, things like Saturday night syndrome, which is somebody falling asleep over with their arm draped over the back of a chair, or old school crutches. But the ones that you worry more about are the fractures, because those are the ones that are irreversible if you don't repair them. Ulnar, where do we worry about the ulnar nerve? Perfect, medial epicondyle. So fracture of the medial epicondyle, which doesn't tend to happen too often. Well, the more common one is cubital tunnel syndrome. So the cubital tunnel around where your funny bone is, if the ulnar nerve is compressed there for any reason, so any sort of increased fluid retention state or inflammatory condition can cause compression of the ulnar nerve there. That's cubital tunnel syndrome, and what you're looking for is, well, failure of everything the ulnar nerve supplies. So wasting of the hypothenar eminence, not being able to do your lumbrical functions, and loss of sensation over little finger and half of the ring finger. And last but not least, the median nerve. What messes the medial nerve up? Yeah, carpal tunnel, perfect. Also, sometimes you worry about the other thing, that more acute thing than carpal tunnel you worry about is supracondylar humeral fractures. They mess with the brachial nerve. The brachial nerve directly supplies, brachial artery directly supplies the median nerve, so that can cause a more acute median nerve palsy. But carpal tunnel, correct, is the main one. Just quickly to say, axillary nerve usually sorts itself out on its own, rarely needs surgery. Radial, if the axon's not disturbed, will come back on its own. If it is, prognosis is worse. Either it takes months or sometimes years, or it just doesn't come back. Median's not too bad, unless it's, again, the secondary to supracondylar fracture. And ulnar, usually, if it's cubital tunnel, the problem is that's picked up quite late. At that point, it's not very reversible, but if you pick up early, surgery is very, very successful. It's mentioned over here, the hand of benediction and the ulnar claw. Just remember, those are things you can get the patient to do if you suspect it. Hand of benediction, you get them to close their fist, stays up, looks a bit like a saint in the Vatican. And ulnar claw, you ask them to open up a fist and you get the same position, except one you're starting off, and you're asking them to make a fist, the other one you're opening a fist. And I'm sure there is a way of remembering it somehow. Carpal tunnel, we'll go through this really quickly because it comes up a lot of the time. It will come up in your SBAs, it might come up in your OSCE, but it is one of the most straightforward things. If the median nerve gets trapped under the flexor retinaculum, you will get symptoms. These symptoms are what happens when you mess up the median nerve. So all the muscles supplied by the median nerve, remember your eccrine meatloaf, will be affected. So your thenar eminence, which hold most of these muscles, will waste away. Sensation of the median nerve, so covering 3.5 digits on the palmar side of the hand, will also be affected, and you get regular neuropathy symptoms such as tingling. It tends to be worse at night, and people might report that they find relief from shaking it or hanging it over the side of the bed. As with most of orthopedics, you want to start off conservative, so your wrist splinting, you might inject them with steroids if it's really not helping, and worst comes to worst, you will have to divide the flexor retinaculum. And your tests, which aren't particularly sensitive, but you get taught how to do them. It's always worth doing them if they come back positive, are Tinel's and Phelan's. And we have an entire table of the causes, or most common causes, of carpal tunnel syndrome.
It spells median trap.
I think they can see that, darling. The thing to think of is that if it's bilateral, you're suspecting a more systemic thing. So, for example, rheumatoid tends to produce bilateral carpal tunnel, so does acromegaly, so does pregnancy, so does diabetes. In fact, if it's bilateral carpal tunnel before the age of 55, you want to rule out diabetes. If it's after, you want to rule out acromegaly, which is something that comes up in PassMed as well. But these are the most common causes. There are rarer causes. You don't really need to worry about them. But learn that table in your own time. You'll have carpal tunnel covered. There's the structure of the carpal tunnel. In the middle, it's really difficult to see the scar from the operation to by the flexor retinaculum. But if you look closely, you can sometimes see it. Tinel's, just a word to the wise. A lot of people end up tapping around here. You want to be tapping sort of right at the base of the hand, so this area rather than here. And Phelan's, if you can't remember it, this is praying to God. Phelan's is hailing Satan. Hail rhymes with fail. Phelan's test, Halen's test, hail Satan. Yeah, you'll never forget it after that. Shoulder pathology, real quick, you want to divide it into two things. The rotator cuff is fucked, or everything's fucked and their shoulder is frozen. Rotator cuff, most common thing is supraspinatus. If it's a young person, they've probably torn it. If it's an old person, it's probably calcified. It tends to happen a lot in athletes. Yeah, don't do Durkin's test in an exam. Tends to happen a lot in athletes. So people who will use their supraspinatus or their rotator cuff heavily, so tennis players, for example, where you test for an exam, one of your specialist tests, you get them to make the gesture as if they are emptying a can. If that elicits the pain, that is a problem. But yeah, you can get injuries to any of the rotator cuff muscles, but supraspinatus is by far the most common, and you won't be asked about any of the others. I can almost promise you I'm willing to bet my own supraspinatus on that. Adhesive capsulitis, if you are stood in front of an OSCE station and the brief is do a shoulder exam on this 53-year-old diabetic, it's going to be adhesive capsulitis. There's a reduced range of motion globally, so it's difficult to move their arm in any direction, but the worst one is external rotation for them. So external rotation is particularly difficult. Diabetes is by far the biggest risk factor. There is a sort of pattern to it, which is it starts off as painful, then it freezes up, and then it gets better, and it lasts around 18 months. With any shoulder pathology, your first line's physio and NSAIDs, and you might have to do steroid injections. You can do surgery for a torn rotator cuff muscle. You can't do it for adhesive capsulitis because there isn't really anything you can do surgically. It says reassure the patient that it's self-limiting, but if you are, this isn't an OSCE thing, but in real life, if you have a patient with adhesive capsulitis, please do not tell them, don't worry, it'll go away on its own, because it is a really, really horrible condition to have. And probably the most important thing is genuinely empathizing with the patient. Look, I know this really, really sucks, and this really, really is painful. We're going to do everything we can. At this point, it's physio. I know that doesn't, you might want an operation or something. Trust me, that won't help. Physio is going to be the best thing for you. I've seen people tell them, don't worry, it'll get better. And they're like, what about now where I can't go to sleep because the pain is excruciating? So just remember, adhesive capsulitis requires a bit of humanity when dealing with those patients. Lower limb. What are the three main nerves we think about in the all week? Yeah, three main nerves where things can go wrong in the lower limb. Femoral, perfect. Sciatic, very good. And the last one. I'm going to ignore superior gluteal. Common peroneal, perfect, yeah. So this is kind of why nerve roots are important. They're important in the upper limb and they're important in the lower limb. Nobody bothers too much about nerve roots in the trunk, for example, and obviously there are none for the cranial nerves. So with the lower limb, you want to consider the femoral nerve, the sciatic nerve, and the common peroneal nerve. If somebody has a femoral nerve palsy, what kind of things cause a femoral nerve palsy? If we start off with that.
Go for it.
Come on, peeps. What causes a femoral nerve palsy?
Could it be something to do with the hip, potentially?
Yay, dislocation. Yeah. Thank you, Nora. Yes, any form of trauma to the hip can screw over your femoral nerve. If you remember that the femoral nerve has both a sort of sensory branch, but also its main thing is supplying the quadriceps. If somebody's really having trouble extending their knee after a hip replacement or they've dislocated their hip, probably a problem with the femoral nerve. Tends to resolve on its own, not too much of a worry. Sciatic nerve, what does that present with if there is a problem with the sciatic nerve?
Yeah, foot drop.
Yeah, foot drop. Yeah, so slip disc can cause it. Shooting pain, wonderful, so sciatica. So sciatica is one of the most common musculoskeletal presentations you will see, definitely in primary care, and you'll see a lot of it in secondary care as well. A lot of the time it can be idiopathic, though the most common causes are slip discs after some form of strenuous exercise, lifting a heavy box, for example. Usually you can manage it rather conservatively, so with NSAIDs, with regular analgesia, physio can help as well. But 10% of patients will require surgery and sometimes symptoms can persist afterwards. So it's not the nicest condition to have. Remember, as with any sort of thing which can cause back pain, exclude your red flags. Touch on those really quickly right at the end. But the last one, common peroneal nerve. What causes peroneal nerve palsies? Common peroneal nerve palsies. And what do they come across as? Or sorry, how do they, what do you, tight plaster cast. Neck or fibular injuries. Stirrups can do it as well, and foot drop is the classical thing. So sciatic nerve, widespread sensory loss with foot drop. Anything that messes with the hip will damage your sciatic nerve. If it goes backwards, remember the sciatic nerve is behind your hip, the femoral nerve is in front of your hip. So if there's an anterior dislocation, your femoral nerve's at risk. If it's a posterior dislocation, your sciatic nerve's at risk. And then common peroneal, something which comes up sometimes. In a common peroneal nerve palsy, it's eversion of the foot, which is spared. If all of these things are there, so there's foot drop and, inversion. Inversion is spared. But if all of these things, the common peroneal nerve palsy symptoms are there, and they also can't invert their foot, then what are you thinking of? It's a very specific thing, annoyingly, but has come up, and consultants do tend to love it. I know Bainan loves this. If somebody can't invert or evert, they've got sensory loss around the common peroneal nerves distribution, they've got foot drop. Remember, inversion is usually spared in a common peroneal nerve palsy. Anybody? Anush, what is it?
I don't know.
Really?
Yeah.
Dude, Bainan.
What is
okay,
it? Go on.
It's a L5 root.
Oh wait, yeah, it is.
Yeah, so it's specific, but if they can't invert as well as either you are thinking of maybe compression at the level of L5, but very specific, has come up in SBAs, is annoying, but I don't know, keep it in the back of your mind. Last thing, limping child, actually whiz through it. 3 things you kind of think about. Basically, if it's a limping child, approach it by age. At least in SBA land, age is what gives you the diagnosis, basically. If it's a little kid, it's developmental dysplasia. You check for it at birth. You will find this in PEDS next year. There are tests for it, which you don't need to know this year. But remember, there are loads of risk factors for it. The biggest ones are babies upside down and refusing to come down head first. So a breech baby, they're at risk because their hips come out first. But loads and loads of other risk factors, such as being female and so on. Problem with not picking it up early is they will go on to develop very, very early osteoarthritis and be crippled. So once it's picked up, usually it can be dealt with in a harness or a splint. It rarely needs surgery unless it's picked up too late. Perth disease, that happens in sort of usually youngish boys, not like toddlers all the way to around year 5-ish. The pathology is thought to be loads and loads of microinfarcts, which cause vascular necrosis of the hip joint. So you'll see a small femoral head because it's not getting blood supply, and you'll see a large joint space. They'll come in with hip pain. Usually it will get better, so there is conservative treatment, but sometimes they will require operations. And all I will say about slipped upper femoral epiphysis is if it is a limping boy who is obese, it is this. It is the most generic SBA question you might ever see. If you see the word obese, limping, boy, it's a slipped upper femoral epiphysis. Usually you can splint it. Sometimes you need surgery. I was going to say stuff about things like Osgood-Schlatter. I've never seen them come up in UCL questions. I know PassMed and all the other question banks love them. Things like Osgood-Schlatter and osteitis dissecans and so on. All the other conditions. I think it's worth knowing about them, like the buzzwords for them. So like Osgood-Schlatter, active child complaining of pain. Usually a teenager, is an athlete. Oh, Osgood. They'll never ask you management. I'm pretty sure they'll never ask you management, but maybe they might ask you diagnosis. I've never seen UCL do it before, but it comes up on loads of the question banks, so there's no harm in knowing it. But yeah, things like I can't remember the other ones actually, but there are loads of them. But that's limping child. Nearly at the end of the ortho, I can hand you over to the more interesting bit. These are the less frequently examined things in orthopedics, but you've got things like your shoulder dislocations. Remember, usually anterior. If it's posterior, either they've had a seizure or they've electrocuted themselves, at least for SBAs. Hip dislocations, usually posterior, require a hell of a lot of energy to dislocate your hip. So usually it's a really, really bad accident in traffic. Knee ligament injuries, they rarely ask you about management, but these are things like your cruciate ligament tears, your meniscal tears. Just know how to pick up on the signs. Usually it's quite generic, something like, oh, football player twisted his foot, swelled up immediately, pain, and now when you pull it forward, it hurts. What's it going to be? It's an anterior cruciate ligament injury. Achilles tendon comes up as well, usually in the context of somebody started ciprofloxacin. Now they felt a popping sensation in the back of their foot. What has happened? Epicondylitis as well, so that's your tennis elbow and your golfer's elbow. Just remember, your flexors and supinators come on your medial side, your extensors come on your lateral side. If you worry about a patient who's coming in with elbow pain, literally get them to supinate against resistance. If it hurts, that's medial epicondylitis, golfers. If you get them to extend the wrist against resistance and it hurts, tennis elbow. And they just get braces. Hip pain, that was basically what you guys have asked about, things like trochanteric bursitis and Osgood-Schlatter's disease. Those are common in real life, not very common in SBAs, annoyingly. Everyone comes in with some form of like transient synovitis, for example, but they rarely ever ask about it. Learn your fractures of the arm, your Colles fractures, your Galeazzi fractures and Monteggia fractures. Those are just pattern recognition. If you can recognize it on an X-ray, it's fine, then you're sorted. Anytime they bring up something like hammer toe or bunions or trigger finger, look at a picture of those to figure out they are conservative management, unless it's really, really bad, in which case they might operate. Know a bit about post-operative complications, things like complex regional pain syndrome, but never really come back. But by far the most important thing for real life, and probably out of non-immediate, like non-acute orthopedics, lower back pain, know your red flags. So, you know, if it is 42-year-old Stephen Briggs, who is an accountant who sits at his desk all day and there's nothing else wrong, he's fine, it's mechanical back pain, give him paracetamol, send him home. If it is 80-year-old Jennifer Edwards, who has a history of breast cancer and she's now complaining of back pain around her, you know, around the area of her chest, shit, that's probably metastatic. So know your red flags are things like if it wakes them up at night, if they've had systemic symptoms, previous history of cancer, focal neurology, all that stuff. Learn it. It's really, really important, not just for exams, it's important for real life. And to summarize, orthopedics in a nutshell, find out it's broken and fix it. And yeah, that's orthopedic. Conservative, medical, non-surgical, always expect a joint examination neuroskeys. Real life, but also if you ever get an orthopedics history station, which you probably never will, ask them about their functional status. Remember, orthopedic problems tend to heavily affect people's ability to function. If you've got a problem with your thumb and you're a musician, or your fingers and you're a musician, that's your livelihood gone. And as was previously asked about, know about your nerve roots, because they are really, really quite important, again, both in real life and as a frequent examination topic. If anyone's got any questions about orthopedics, ask them at the end, because I think we should switch to rheumatology. Yeah, in the chat. We'll switch over now. Anusha's going to take rheumatology. Yeah, not expected to know about advanced trauma or details of operations. Don't worry about that. Switch to rheumatology. I'll take over to answering questions in the chat, and I will hand over to rheumatology man.
So this is the kind of stuff we're going to be talking about today. We're going to be talking about degenerative joint disease, which is kind of boring. So like, we'll spend some time on the cool, interesting stuff that any of you who did Mod B at the WIT would have missed out on. I'll touch on metabolic bone disease. There's a couple of really good slides in this presentation that you can read in your own time, because it's all just guidance. And it's kind of boring to hear me talk about it. And the way this is going to work is, I know a number of you in the audience, and I know that you've done Module B, so I'm just going to pick on you. So sorry. It's just easier than waiting for messages. Right. Let's have a look at the list of people we have. Right. Who's done Module B? Vikram, unmute yourself.
Hello.
Hi, Vikram. Tell me what you see.
It's a swollen knee.
It's a swollen knee. What would you describe? What else would you say about this knee?
It's red. Hot to touch, probably.
It's probably hot to touch, exactly. Yeah. So the first thing I want in your head is septic arthritis. If you see a red hot swollen joint.
So I don't think you're listening.
Someone mute themselves if you're not muted and you're not muted. Yeah. So if you see a red hot swollen joint, the first thing you're going to think of is septic arthritis. Like, do not think of anything else until you've ruled this out. And this is really dangerous. Like, you can end up without a joint within like 24 hours, probably less. And they'll have constitutional symptoms. They'll have this red hot swollen joint. They won't be able to wait there. And you're going to send off your standard bloods. You're going to send off a joint aspirate. That's really important. Let me unmute Vikram again. Vikram, when do you not do a joint aspirate when you're suspecting septic arthritis?
Don't you give it before you give them antibiotics? You do the joint aspirate before.
I mean, you do, but in what situation would you not do a joint aspirate at all? As in, you wouldn't do it in like as a medic?
I'm not sure.
So if they've got a replaced joint and you're worried about septic arthritis, you're going to refer to orthopedics. They're going to take them to theatre and they're going to do it there. Like you still do it, but like you do not do it without a sterile environment, because a joint replacement can get completely destroyed if you do an aspirate. And your management for this is going to be Fluclox or clindamycin. And if you're worried that it's invaded the bone itself, you're going to give them fusidic acid. In the chat, can anyone tell me what the most common causative organism would be? Yes, Staph aureus is the most common causative organism for this. So that's why we give Fluclox, which is especially good against Staphylococcus aureus. Fine. You've ascertained that this is not septic arthritis. Time to pick on another person. Izzy, unmute yourself. Izzy.
Yep.
What else could be causing this?
So if it's like an acute onset of pain, you might be thinking about a crystal arthropathy like gout or pseudo gout.
Shall we talk about gout first?
Yeah, so gout is normally first metatarsal joint, whereas pseudo gout is often bigger joints like the knee.
Yeah. Sorry, continue.
So gout is negatively birefringent needle-shaped crystals, whereas pseudo gout is rhomboid positively bifringent crystals. Risk factors for gout are like high purine diets, like eating like seafood, meat, chronic kidney disease, being overweight. It's like classically like older overweight man, whereas pseudo gout is more common in females, I think.
Yeah, perfect. And you can all see the slides, but management for like gout, you're going to start with NSAIDs, and whenever you give NSAIDs, you always give gastric protection. Colchicine is like pretty much designed for gout, but you don't use it because it causes really bad diarrhea. So unless they've got really bad renal function, NSAIDs. And remember, like allopurinol is really good for prophylaxis, but don't start it until at least 3 weeks after an acute flare. Izzy, do you know what the mechanism of action of allopurinol is? Or does anyone, if anyone wants to put it in the chat? Do you wait with allopurinol? What do you give in those couple of weeks? You treat the gout episode, as in you treat it with NSAIDs or colchicine. So allopurinol is a xanthine oxidase inhibitor. That's just something that comes up in SBAs. Like, you don't need to know anything else about that. Yeah, exactly, perfect. So related to xanthine oxidase, does anyone know what inflammatory bowel disease drug you need to change the dose of if they're on allopurinol? This is another random niche SBA fact. Drop in the comments. I'll wait like 5 seconds. Yes,
nice.
Azathioprine. Yeah, so azathioprine is metabolized by xanthine oxidase. If they're on allopurinol, that will basically build up and they get lots of the product of that being metabolized. So you need to quarter the dose. That's good knowledge. Right. Gout or pseudo gout? Drop a message. Yes, correct. This is gout. These are the classic, really colorful rhomboid not rhomboid, needle crystals. Mihir, what sign can you see on this X-ray?
Chondrocalcinosis.
This is chondrocalcinosis. So if you can see that there is like this white thready material between the two bones, that's not normal. That's calcium deposition. And Mihir, what like disease is characterized by chondrocalcinosis?
Pseudo gout.
Exactly. Right. So pseudo gout. Yeah, we've already talked a little bit about this. So instead of uric crystals, we've got calcium pyrophosphate crystals, and it commonly affects like joints that are already damaged by usually osteoarthritis. And you've got loads of different risk factors again. Age, hemochromatosis causes this as well. And again, you're going to investigate the same kind of way. You're going to ask for it. You're going to find these weird crystals that I'm about to show you. This time, use NSAIDs. So that, if I go back to that picture, if you can see the thready white stuff between the two bones, you can't see my mouse. That's chondrocalcinosis. That's calcium in the joint. It should be like clear black between the two bones. Does that make sense? I'm going to move on. No worries. Fine. And this is your classical joint aspirate for pseudo gout. Just a bit erratic and rhomboid-shaped crystals. Fine. And now to the least interesting thing in all of rheumatology, osteoarthritis, which is the most commonly used misnomer in medicine because there is no inflammation. What's the drug you don't give in an acute exacerbation? You don't give allopurinol in an acute gout flare. You wait 3 weeks before you give it, and that's prophylaxis. There should be what between the two bones? Air, like nothing. It should be clear. It should just be synovial fluid. Cool. So I'm not going to spend a lot of time on osteoarthritis. It's just not inflammatory. They get morning stiffness spelled wrong for less than 30 minutes. It's worse at the end of the day. Conservative medical surgical is like how you should be structuring all of your answers in medicine. Joint replacement is the only definitive management for this. Right. More interesting. Not more interesting stuff. Time to pick on another person. Right. Prina, what are the 4 X-ray changes seen in osteoarthritis?
Hi. Can you?
Yeah, we can hear you.
Oh, so narrowing of the joint space.
So loss of joint space?
Yep. You get.
You're breaking up. You're not messaging us. Sorry.
Yeah, I'll type it. Sorry.
Cool.
Oh, damn it. Her voice was working towards the end.
Yeah. Osteophyte formation.
Sick.
Subchondral cyst.
Wonderful.
Subchondral sclerosis. So yeah, there's this really great acronym that you should all be using called LOSS. Learn that. It will probably come up. It comes up on PassMed. Right, another person to pick on. Who shall I pick on? This is great. Nathan Parakill. Can you hear me? I can't hear you.
I don't think he's here yet.
Okay, never mind. Another one. Rosha.
Oh my god, I'm so sorry. I've been calling you Rose this whole time. God, sorry.
What can you see on this image? I'm going to... Oh, lots of background noise. That's fine. Yep, so this is classical ulnar deviation. And does anyone know what diagnosis this goes along with? If there's one thing you should know from all of rheumatology, it's this. Yes.
Yes, wonderful.
Rheumatoid arthritis. Okay. What could this also, if you saw a patient with this deformity, but when they put their hands together to do the prayer sign and they went back to normal, what other disease would this be?
Ooh, niche question. I love it. I see.
Yes, that would be lupus. So
Nice one.
that's called Jacquard's arthropathy. So it's exactly the same findings as you'd see in rheumatoid arthritis, but they're deformable. So that's like the kind of niche question UCL loves. Fine. Inflammatory arthritis, right? I'm going to pick on someone else who hopefully doesn't have background noise. Right. June? Can you talk? Who's JUN? Okay, no, I was just going to ask you what kind of things you were looking out for in a history, but everyone can type, I guess. Oh, fair.
That's
right.
fair enough.
Morning stiffness. Okay, how long for? Yeah, so it needs to not be less than 30 minutes. And is it going to, yes, it's relieved by exercise, not by rest. So it's going to be better at the end of the day rather than worse, as you clear like the inflammatory molecules. Yeah, fine. Rheumatoid arthritis. Joints affected, large or small? Generally. Small joints. Exactly. Hands and feet is your classical picture. Also, yes, not DIP joints. Diagnostic tests. What investigations are you going to do? Start cheap. They're not cheap. None of these are cheap.
I like it. I mean, if you're at the free, it doesn't matter.
I mean, if you're at the low free, you can go for it. Yes, inflammatory markers. So you're going to do inflammatory markers. You're going to do rheumatoid factor, and you're going to do anti-CCP. You'd also do an ANA because everyone with autoimmune condition gets ANAs. So the important thing to remember here is rheumatoid factor is sensitive but not specific. Anti-CCP is specific but not sensitive. And anyone who has either of these either of these antibodies has a more aggressive form of the disease, so you'll have to treat them more aggressively. Someone mentioned the DAS28. Izzy, do you want to tell us what you know about the DAS28? Because it's not in my slides.
Whoever's guessed, I love you.
It's just where you survey like all of their joints and just feel all their joints, like their hands and stuff, and map out if it's a symmetrical or a non-symmetrical arthritis. Basically, is all I know.
Yeah, that's exactly what it is. It's a scoring system that's used to determine when you need to up their treatment regimen. People who have large joint involvement tend to score lower on the DAS28, which means rheumatoid arthritis is less likely. A cutoff of 6.1 on GMARDs is an indication for biologics, but we'll talk about that later. And yeah, management, NSAIDs, DMARDs, biologics. By the way, these are the answers to almost every condition in rheumatology, so I'm not going to ask you again. Right, so what deformities might be present? We spoke about ulnar deviation, but you also get boutonniere, swan neck. I mean, there's also Z thumbing. There's loads of findings. You should learn these for exams. Someone with rheumatoid is quite likely to come up in exams generally because they're stable.
Yeah.
Although scleroderma patients are more likely, but we'll talk about that in a minute. Fine. Right. Who am I going to pick on next?
This is.
Right. Christy.
Hello.
Right. What does this lady have potentially?
SLE.
So this could be SLE. Considering this is a rheumatology talk, it is likely to be SLE. What other things could be causing this? Any ideas?
Sarcoidosis.
Yeah, so like another cause, if they're short of breath, could be sarcoid, which causes a very similar rash, although it would mainly be on the nose and wouldn't spare the folds. It could also be like an infectious process. Could it be systemic sclerosis? It is unlikely to be systemic sclerosis because that causes telangiectasia that I'll show you in a minute. Carcinoid tumor causes flushing, which you're absolutely correct, but this is a very specific distribution. Christy, don't leave.
Rosacea is good. Rosacea is a big
rosacea is much more common than lupus and is actually a more likely diagnosis.
Yeah.
Yes, classic house mean. Mitral stenosis could also cause it, but again, it's a very limited distribution and it goes over the nose.
Also, malar flush would cause a flush rather than a rash. That was a rash.
Yeah. I've lost the slides. Give me a second.
You're on the house one. Let me answer that.
Right. I've just given away loads of spoilers, but so lupus is like a truly systemic disease. And yeah, everyone's like, lupus is really exciting, but most people with lupus will present with nothing other than fatigue and weight loss. That is the majority of lupus. And alongside this, they may have cutaneous manifestations, classically the malar rash, and they have like small joint pain that tends to mimic rheumatoid arthritis. And your classic demographic is this young female Afro-Caribbean. Yeah, don't worry about rosacea. It's a year 5 condition. You don't need to know it. It's just an important differential that you can show off with an anoscopy. And like, it is like, oh, there's a good acronym in the comments if anyone wants. But yeah, there's loads of systemic manifestations of lupus. So it can cause any form of glomerulonephritis. So it can cause a nephrotic syndrome. It can cause nephritic syndrome. I think it can also cause like interstitial nephritis. It causes havoc in the kidneys. It can cause arterial and venous thrombosis. It can cause a non-infective endocarditis that like niche knowledge again. It can also cause secondary vasculitis, and it can cause serositis. Christy, what is serositis?
Inflammation of your serositis.
Yeah. Is it inflammation of the serosa in your body?
Growth.
All right, Dana.
Yeah. So it's all serositis is. It's inflammation of serosa, which involves your which involve your pleura and your pericardium mainly, but it can be other things as well. But yeah, that's very common in lupus as well. Fine. Right, I'm gonna pick on someone else. Izzy, what is this?
It's like a bilateral vasculitic rash.
That's exactly what this is. Could this be a feature of lupus?
I guess if it's caused a secondary vasculitis.
Yeah, it's not a very common finding in lupus. So lupus serology is kind of complicated compared to the other things. So there's loads of antibody tests and there's other important tests that you're going to do. So can someone type out some antibodies that you might do for lupus? What is the commonest antibody that you're going to test for in lupus? Yes, ANA, which stands for anti-nuclear antibody. Double-stranded DNA also. Anti-Smith is another one. So ANA is the most sensitive test. 95% of people with lupus will be ANA positive. Most rheumatologists say that if you don't have ANA, you're unlikely to have lupus. A lot of them tend to be rheumatoid factor positive as well. And then the important specific antibodies are these group called the extractable nuclear antigens. If you get antibodies against those, you're much more likely to have lupus. So anti-Smith is the most specific and shows aggressive disease. Like these people do not do well. They will go into renal failure. And Roux-en-La are other ones. What other condition do you get Roux-en-La antibodies in? We will talk about antihistone antibodies in a bit. Yeah, Sjogren's syndrome.
Good.
Rheumatology is just antibodies. If you know the antibodies, you're going to get all the more. The other important tests, can anyone tell me what another important test for lupus is? That's less expensive. CRP, ESR. So,
yes.
And C3, C4. So are CRP and ESR both raised in lupus?
Okay.
No, they're not.
Good.
So it is a cause of a normal CRP and a raised ESR. C3 and C4 are low. Does anyone know why?
Oh, love this question. Good. Yep.
Yep, that is exactly why. So lupus is a disease that's characterized by immune complex deposition. These immune complexes consume C3 and C4. And do not forget renal function, because 30 to 60% of patients will get glomerulonephritis, and it's like pretty horrific. Just remember to be specific. So complexes are low because they're used up due to complement is used up by complexes, not due to chronic inflammation alone. Other conditions also cause chronic inflammation, but they have normal C3, C4.
Yeah.
Fine. And then like lupus has all of these associated disorders that we'll go through in not too much detail. So we talked about antihistone antibodies, which go along with drug-induced lupus. There's also a specific type that you need to know that's a side effect. So drug-induced lupus, there's an acronym HIPP. I don't know what that stands for, but everyone uses it. These are the 4 drugs that commonly cause drug-induced lupus. Yeah. Test for antihistone antibodies. The symptoms they'll get, they tend to get the malar rash when they take any of these drugs, but they can also get joint pain. They can also feel like pretty rotten after. Fine. Does anyone know what this is? Just drop a message. This is pretty niche, but like, if you know, it's quite useful. So this could be erythema multiforme. So that's fair. Erythema multiforme is a common effect of which organism causing pneumonia? Well, we're talking about erythema multiforme. Mycoplasma pneumonia causes erythema multiforme classically, yeah. This is not a discoid rash because there is no, well, it could be, but there's no scarring and it's too superficial. So this is subacute cutaneous. So this is subacute cutaneous lupus. So this is the commonly caused by PPI usage. Psoriasis, you get more like plaques. They're like raised off the skin. So this is caused by PPIs. It's called subacute cutaneous lupus. That's all you need to know about it. It's caused by PPIs. It looks a bit like erythema multiforme. So this was, Gene, this is discoid lupus. So the difference between discoid lupus and the other forms is like discoid is scarring. Like they don't recover from it. And if it happens in the hairline, they lose hair permanently. They get like permanent alopecia. Discoid lupus is really rough, but they don't tend to get other systemic involvement. It tends to only be skin involvement. It's managed by dermatologists. Fine. Right, I'm going to pick on someone. Fady, patient complains of dry eyes and dry mouth. What is this? Ankit, this is not scleroderma. No idea. Anyone? Does anyone know what this is called? If a patient complains of dry eyes and dry mouth, this is not Sjogren's syndrome. Yes, someone got it. Yes.
Yes, Sarah.
So this is Sicca syndrome or a Sicca complex, and Sjogren's is a cause of Sicca syndrome. It is not. So everyone who has Sjogren's tends to have Sicca syndrome, but not vice versa. So Sjogren's, you'll have small joint pain, fatigue, dry eyes, dry mouth, and you get, as we spoke about, you get anti-Rho, anti-LA antibodies. But like there are many other causes of like a Sicca complex. So drugs such as antidepressants cause it, dehydration can cause it, diabetes can cause it. All 3 of these are more common than Sjogren's syndrome. So don't jump to Sjogren's. Fine. Does anyone know what this is called? This pattern on the skin? Yes, diabetes is just because they're dehydrated. Yes, this is levator reticularis. Do you know what condition that would go along with? Yes, antiphospholipid syndrome, which can occur as part of lupus or can occur independently. So this is one of the causes of venous and arterial thrombosis. And like important things in the history is if they're female, they might have had recurrent miscarriages. And there were 3 antibodies you're going to test for this condition: anticardiolipin, lupus anticoagulant, and anti-beta-2 glycoprotein. And remember to rule out other causes of thrombosis. Can you list me some causes of thrombosis that are more common than this? Because antiphospholipid antibody syndrome is rare. Mod C, you might not have done it, but like if you have done it, list some causes. Malignancy is the most important cause.
Yeah.
Oral contraception is another very important cause. Surgery is a cause. All three of these tend to be causes of venous thrombosis. Does anyone know any causes of arterial thrombosis? Activated protein C resistance is a cause. Yeah, anything else? There's also factor V Leiden, and you can also get protein CNS deficiency. Yeah, exactly, perfect. Polycythemia is also a cause, but it tends to cause hyperviscosity before it causes thrombosis, but definitely. Right, fine. And like, how are we going to manage lupus in all of its many forms? Like, hydroxychloroquine is like the drug of choice for lupus. Does anyone know what we're monitoring with hydroxychloroquine? Eyes. What about the eyes? Can't just say eyes. Visual acuity, yeah. So they get like retinal toxicity. I think they get like some weird macular spot. Perfect. And if they do happen to get organ involvement, you need to give them mycophenolate mofetil. Does anyone who's done Mod C, do any of you know what other thing this is used in? It's a really potent drug. Renal transplant, exactly. Yep, organ transplant immunosuppression. And then for their skin involvement, you're going to give them sun cream because they need the protection, and you can give them steroids for any flares. Fine. Polymyositis, dermatomyositis. All right, number one thing to remember, polymyositis is exactly the same, except for you don't get the skin manifestations. What are the three skin manifestations you can see on the slide? June, you do not need to know the different medications for different organ involvements. So the heliotrope rash is the bottom one, which is like the dark eyes. Gottron's papules are the top left, and the Scholl sign is the top right. Cool. If you've got dark eyes, what other two medical problems do you want to consider? One of them is covered in renal, one of them is covered in trauma. If you've got dark purple eyes. So panda eyes is goes along with basal skull fractures exactly. What's another cause of panda eyes? Retroyear hemorrhage. I'm assuming that's autocorrect. Retrobulbar hemorrhage. I'm not actually sure about that. It could be. Sorry. So panda eyes are also found in amyloidosis. Google it. They look kind of creepy. Fine. And the classical like presentation of myositis is they get this proximal muscle weakness and pain. And your investigations you're going to do is creatine kinase. You're going to do muscle biopsy. If you're at the Royal Free, they're weird and they might do it under MRI because they have tons of money. You can also do an EMG if you're worried about neurological problems. And these are the antibodies you're going to be worried about: ANA, anti-Jo1, anti-Me2, and anti-SRP. SRP being signal response peptide or something. What was the renal cause? Amyloidosis. Both AA and AL amyloid can cause dark eyes, or panda eyes, whatever you want to call them. Fine. So here's a question. Dermatomyositis is the cause of lung fibrosis. Which of these antibodies is most associated with lung fibrosis in dermatomyositis? Does anyone know this? No, so anti-Jo1 goes along with lung fibrosis. It's called the anti-synthetase syndrome. It's just another niche thing they can ask you about potentially. Yeah, you manage them by immunosuppressing them. Like, have you noticed? Like, it's literally the same answer for every single condition. And this is a useful list that those of you who go to Bain will know about, but these are the causes of the proximal myopathy. If you organize it in accordance to your surgical sieve, there's loads of infective causes. Trauma can cause muscle pain, obviously. Myositis and other connective tissue diseases can all cause like proximal myopathies. Metabolic important ones, hypo and hyperthyroidism. Know which ones are painless and which ones are painful because they can do both. And then rhabdomyolysis, which is secondary to statins. Neurological causes of myopathy. So like if it's neurological, it's not really a myopathy by definition because the problem's just before the muscles, but like good point. Another important thing to consider in your clinical practice, if you see dermatomyositis, you should always investigate for an underlying malignancy. In adults, over 50% of them are associated with a malignancy. So it's not good news. Fine. And there's also some differentials where you get like that cause myopathy without, they say myopathy, but there's no actual weakness. Polymyalgia rheumatica that we'll talk about, fibromyalgia, depression, osteoarthritis. Fine. And then quickly, systemic sclerosis. By the end of your 6 years at UCL, make sure you've seen a patient with systemic sclerosis. There's millions of them at the Free. Because it's remarkably rare, but they have a ton of them at the Royal Free. And you can split it into two types, the old CREST syndrome, which is now called limited cutaneous, and diffuse cutaneous, which was the old scleroderma. Skin fibrosis is more common in limited cutaneous, like it's more aggressive, and you'll notice it earlier. But in diffuse cutaneous, they also get it, and it involves the entire body. They tend to have worse organ involvement in diffuse cutaneous. The antibodies are different. Centromere for the central limited cutaneous, and SCL70 and RNA polymerase in diffuse cutaneous. Again, these slides are for your reference. It's not actually that useful for me to just read them out. CREST, what does C stand for? This is where you get to interact. Calcinosis. So if you can see the fingers, bits of the fingers have gone nice and white for us. That's calcinosis. R, Raynaud's. What distinguishes Raynaud's from pale fingers or just feeling cold? There is a specific pattern of color change in Raynaud's. Yeah, it's a 3-color change. What's the 3-color change? Yeah, so it goes white, then it goes blue. It definitely does not go green. So it goes red after blue because they get this, like reactive hyperemia as the vessels open up again. What's E? Esophageal dysmotility. Yeah, it's the American E, sorry. S? So S is sclerodactyly. That just means that they've got like tight skin on their fingers. And then the last one is T. So this is what we were talking about. When I said telangiectasia, this is what this will look like. Can you see how this is quite different from like the malar rash? Like they're distinct spots. Like you'll be able to tell the difference between telangiectasias and a lupus-like rash. Fine. What's next? Oh yeah, management of this. Yeah, mycophenolate and iloprost are your mainstays of management, and you've got loads of complications. Interstitial lung disease is incredibly common. Pulmonary hypertension is common. You can get systemic hypertension, and there's this thing called the scleroderma renal crisis, which basically kills people. Seronegative arthritis. These are the 4 you need to know. I'm only going to talk about one of them, which is Angst-Bond. But what genetic marker are we interested in for all of these conditions? HLA-B27, yes, exactly. What GI condition also goes along with HLA-B27? Ulcerative colitis is the correct answer. No, that's year 5 stuff, never mind. Ankylosing spondylitis. So classically, young men with lower back pain and stiffness, insidious onset. When you do your back exam, which is another thing that can come up in your exams, you'll notice reduced lateral flexion and forward flexion. what special test can you use to test for ankylosing spondylitis? Schober's test. In an OSCE, it takes a lot of time to do a Schober's test, to do the modified Schober's test with your 2 fingers. And like it's associated with all of these other conditions. Ulcerative colitis in particular is more associated with B27 than Crohn's disease. What other GI thing goes along with ulcerative colitis? Yeah, primary sclerosing cholangitis, which is a terrible disease that will eventually require liver transplant. Okay, and treatment for ANCSPOND is important because you do not use disease-modifying agents. You go NSAIDs and exercise. If that doesn't work, you go straight to biologics, which are anti-TNFs. And the way there's a scoring system that you don't need to know, but like if they score a certain amount on the BASDI score, you get anti-TNF therapy. Do you know what's first-line management for ankylosing spondylitis if they have both UC and ankylosing spondylitis? Yeah, you go straight to anti-TNF therapy because NSAIDs are contraindicated in ulcerative colitis. Perfect. So we've also got loads of systemic manifestations that you can learn as the 6 A's. The most common cardiac finding is AV node block, not aortic regurgitation. That's second. Apical lung fibrosis, anterior uveitis. What does anterior uveitis look like? Like, what would it look like if you saw a patient with anterior uveitis? White stuff in the eye is a very niche finding that you don't need to know until next year. But yeah, you get painful red eye and you get like big blood vessels leading up to your iris. Achilles tendonitis. Ankylosing spondylitis causes this thing called enthesitis. So enthesitis is pain at the insertion of any of your tendons. Achilles tendonitis is the most common enthesitis you'll get in this condition, but it can be any of them. And because any chronic inflammatory condition can cause amyloidosis. All right. Right, causes of apical lung fibrosis. Some of you will enjoy this. Can anyone list me any? Tuberculosis is a classical cause, so that's an infectious cause. Pneumoconiosis, yeah. Borreliosis is more common. So like so all of these allergic ones you can classify into extrinsic alveolar, extrinsic allergic alveolitis. But yeah, so there's like a good acronym. That's a bit rude, so I won't read it out. But these are like the main ones: borreliosis, radiation, extrinsic allergic alveolitis, ANCSPOND, sarcoid, TB. Anything that's not in this list is the other stuff. So I think coal workers and the other like weird allergic ones, environmental ones, tend to be lower lung fibrosis actually. I'm not reading it out for you, you child. Right, last like big topic, vasculitis. How are we going to subdivide vasculitis? Everyone fell into the trap again. No, before we go into the size of vessels, how do we divide vasculitis? Yes, primary versus secondary. So give me some causes of secondary vasculitis. Drugs, lupus, yeah. Some infections as well. So hepatitis B and C can both cause secondary vasculitis. And it's really important to remember the secondary causes because they're much more common than the primary causes. Primary vasculitis is quite rare. All right, so we'll talk about primary vasculitis. We're going to split it into large, medium, and small. Give me an example of a large vessel vasculitis. GCA is the most important vasculitis you need to know about, and Takayasu is also common. Medium ones, there's 2 as well that you need to know about. Polyarthritis nodosa is one of those. The other one you don't really need to know about this year is Kawasaki's disease. And then, yes, exactly. And then small vessel vasculitis subdivides into two more categories. What are those two categories? Yeah, so immune complex or antibody mediated. So we'll get back to GCA because that's really important. So we'll talk about that separately. Takayasu's is a condition that mainly affects East Asians below the age of 55. They get inflammation of the aorta. It kind of presents with changes in pulses. You don't need to know that much about it. Polyarthritis nodosa can affect anywhere in the body, generally presents with joint pain, and is one of the causes of pancreatitis. Kawasaki disease causes coronary artery aneurysms in babies. You don't really need to know about it for fourth year. So what are the two antibody-mediated vascular lithides that you need to know about for fourth year? One of them is much more common than the other. Churg-Strauss, yeah. So Churg-Strauss is the more common of the two. And Wegener's is the less common of the two, GPA, whatever you want to call it. So just remember the antibodies. And the classical presentation of GPA is they'll have like hemoptysis, they'll have renal failure because they can get glomerulonephritis as well. Churg-Strauss is a triad. Does anyone know the triad of Churg-Strauss? Again, it's like something that comes up in exams. Adult onset asthma is one of you three. Rash on the buttocks is not one of them, sorry. It is very important. We'll talk about it in a minute. Eosinophilia. There's one more. It's just vasculitis, sorry. That one's, no one ever says that one. But yeah, Churg-Strauss is a triad of eosinophilia, adult onset asthma, and vasculitis. Sinusitis and saddle nose tends to go along with GPA rather than Churg-Strauss. What's an important differential for someone presenting with a saddle nose that's much more common than GPA? Sinusitis is both, but it is actually more common in Wegener's. So saddle nose deformity, yeah, septum infarct is actually much more common. And you know what drugs cause septum infarct? Yeah, so cocaine. Cocaine is a much more common cause of a saddle nose than like Wegener's. So if you see a saddle nose, don't get that excited in London. Fine. And then immune complex mediated, you get good pastures and cryoglobulinemic. And the one I forgot about is you also get henoxin line purpura, which is presents in children. It causes a rash on the buttocks. It causes joint pain, and it can also cause a glomerulonephritis. Yeah, exactly. That is the rash. Fine. And we'll talk about giant cell arteritis because it's so it's super, super important. It's a cause of irreversible visual loss. You need to know it in 3 different specialties. You need to know it in rheumatology. You need to know it in neurology as it's a differential for headaches. And you also need to know it for ophthalmology next year. And it's associated with polymyalgia rheumatica, which is like this kind of non-specific condition where you get proximal muscle pain and girdle pain. And your investigations for GCA aren't important, to be honest. You're going to do inflammatory markers first off, and then you've got like these 3 different more specific tests. And realistically, if you're confident that it's GCA, you don't care about the results of these tests. You're just going to treat it as GCA. Some guidance that's quite important that changed recently. If they've got no visual symptoms, you're going to treat them with high dose prednisolone, so 80 milligrams of pred, 60 to 80 milligrams. If they've got visual symptoms, that's not enough. You're going to give them 3 pulsed doses of 500 milligrams of methylpred. That's a ton of steroid. That's the most steroid I've seen given in any condition, more than you see in oncology. So make sure you give them bone protection before you give them anything, because that's literally going to melt their bones. And you always taper down steroids when you give them to people. Like, you do not suddenly stop steroids. What is the dosage again? It's on the slide. So it's once a day, sorry. Taper down. So why do we taper down steroids? Addisonian crisis. What does that mean? Addisonian crisis is basically you've been taking steroids for a long time, so your adrenal glands shut off. So if you suddenly stop them, you've got no cortisol. So all the metabolic stuff in your body stops working pretty much. Steroids have lots of side effects. You are correct. You should learn all of those side effects. I'm not going to go over them because they're easily available. You can also use this biologic nowadays called tocilizumab. What investigation can you not use to monitor GCA if you're using tocilizumab? I'll answer that question in a minute. Inflammatory markers, exactly. This normalizes your CRP and ESR. You can't use it to monitor anymore. Yeah, tocilizumab is IL-6. I'll talk about that in a minute. What's used for bone protection? We'll talk about, well, I won't talk about osteoporosis. I'll briefly mention at the end. But you're going to use your standard osteoporosis medication, so bisphosphonates, exactly. All right. Drugs. These are the main drugs you need to know for rheumatology. I have clearly missed out steroids because I'm an idiot, and also NSAIDs, but I thought those were pretty self-explanatory. Know about what kind of investigations you want to do before you start these drugs, know about the side effects of these drugs, and know kind of what conditions you're using them in. Methotrexate is the best for rheumatoid. Hydroxychloroquine is used in everything because it has the best side effect profile. Mycophenolate is for serious organ involvement, is the way I tend to remember it. And these are in my opinion, these are the three most important biologics you should learn, but there's a whole list that you could learn. Can I repeat what drugs for what again? So methotrexate is best for rheumatoid. Hydroxychloroquine works best in terms of side effects. It doesn't have that many, it tends to be quite well tolerated, so you can use it for a lot of things. Mycophenolate is the strongest of these drugs, so you prefer to only use it in heavy organ involvement. Fine. So anti-TNF therapy revolutionized rheumatology. It changed people from being disabled and turned them into people who can live normal lives again. So that's the most important drug. I remember to test for tuberculosis before you put anyone on this because it'll reactivate their TB. Literal first year revision, TNF alpha is a really important immune mediator in the body. So blocking that shuts down a lot of inflammation. Does anyone know what cells express CD20? Taking you back to first year, yay. Doesn't everyone miss that? B cells, exactly. So if I knock out your B cells and I deplete them, what are you going to stop producing? Antibodies, exactly. So rituximab is used in loads of different conditions. It's really good in rheumatology, in all of these antibody-mediated diseases. So it's really good in rheumatoid. You test for TB just before giving anti-TNF or all immunosuppression. Realistically, this is what happens. Anyone who is diagnosed with a rheumatological condition is going to be tested for TB immediately because they're going to get immunosuppression. But yeah, you test it for all of them, pretty much. Yeah. So CD20 stops antibody production. Do you know what other conditions outside of rheumatology they love rituximab for? Sorry, I'm trying to overlap. I know there's people here who haven't done Mod B and have done other stuff, so I'm trying to make this for everyone. Nephrology, yeah. So do you know what they use them for in nephrology? Cancer, heme, yeah. So heme is the big place where they use rituximab. They use rituximab more in heme than they do in rheum. So it's used for loads of cancers. You need to learn about the R-CHOP regimen for one of the cancers. I can't remember which one, but yeah, learn that. Rituximab's really good. Fine. TLDR of rheumatology. Look at all of these cool conditions that mimic every other condition, and then it's not those because they're actually really rare. it's always osteoarthritis. Everybody loves steroids and immunosuppression until they don't. That's literally the takeaway from rheumatology. Know your hand exam, because it can come up. It's like an easy OSCE station. It's also like the hardest to do in time. Before we move on, right, so there's a couple of slides here on metabolic bone disease. It's all guidelines. Do you want me to talk about it, or do you want to read it? Because I don't see the point in talking about it. Just message if you have. If anyone wants me to talk about it, message me. Cool. I don't want to read it for you. The one thing we will talk about is Paget's disease of the bone. So remember that there's two different Paget's disease. You only need to know about the bone one this year, and it's one of the causes of an isolated raised ALP, and you treat it with bisphosphonates. Google what the x-rays look like. There might be one on the next page. There is not. I've got some SBA cases from the people who did this lecture last term. Would you like to go through the SBA cases, or do you want to do them in your own time? If anyone wants me to go through them, we can go through them, but like, it's up to you. Go through them, that's fine. Let's go through them. Right. I'm not reading this out. I'm going to pick on one person to answer each of them and explain the logic, if that's okay, because otherwise this isn't useful. Right, Alexis, considering you haven't done Mod B, this will show us how good this lecture has been if you can answer this question. Do you want to unmute yourself so you can explain your logic as well?
Wait, I'm reading.
That's fine. Her hip x-ray is shown. Oh, apparently it's not shown. I may have forgotten. Let me find you the hip x-ray. Give me a second.
I think it might have been the first x-ray that I showed you guys.
I'm going to scroll up.
Right. So it was a extracapsular fracture, and it was subtrochanteric.
Yeah.
So
Not
it's
1, not 5. I can't remember what's in between.
So subtrochanteric was the lowest level of fracture. So it was outside the hip. It's further down. It's almost in the shaft, but not quite.
You may as well consider it a shaft, pretty much.
Yeah, it's basically a shaft fracture. So which of these?
What does the shaft of a bone have in it?
Oh, the number 2, because it's the one that, like, I remember what it looks like, and it goes down a shaft.
Nice one. Yeah, perfect.
Yeah. Yeah, so discharge with NSAIDs is obviously wrong, and I refuse to explain why. Dynamic hip screw is used for displaced intracapsular fractures. They're not long enough to go into the shaft of the bone.
Yeah.
I mean, hip replacement isn't going to solve it. IM nail is the only one that's really long enough to fix this problem.
Remember, DHS is intratrochanteric. If you see it in an SBA, that's it.
Yeah. If it's in the shaft, a nail is the way to go. Fine. Yeah. Right. Who shall I pick on next? Vikram, I'm going to pick on you again, because I don't know who else has done 1B. Has Vikram left? That would be awkward.
I think he might have.
Yeah, that's fine. Who else has done 1B that I know of? Izzy, can you answer this one?
So you wouldn't give allopurinol because they're in an acute flare and that'll make it worse. They've got kidney disease, so you're not going to give them NSAIDs. I mean, lifestyle advice is great considering, but there's kind of nothing to suggest that they're overweight specifically in this scenario, even though it's slightly implied. So I think I would give colchicine.
It is colchicine. So like this is a really good thing to do. So when you're stuck in an exam, make sure you rule out the stuff you know is wrong, because it'll narrow it down. Like, it'll make it way easier, even if you're going to guess at the end. So yeah, lifestyle advice isn't going to do anything at the moment. The Buxostat we didn't talk about. It's another prophylactic drug you can use for gout. Read up about it. Naproxen is an NSAID, so don't give that because they've got stage 3 CKD. But yeah, exactly what she said. Fine. If you've got any questions about any of these, just drop them in the chat. Right. Does anyone in particular want to answer this one? Yes, the 3-week wait also applies to Febuxostat.
Yep.
Rosha, do you want to answer this one while you're at it?
I think there's a problem with background noise, wasn't there?
Oh no, it's okay. It's okay now.
Sweet,
Right.
Okay.
Invests with swelling and pain in the MCP joints of both hands. She's also been experiencing fatigue and unintentionally lost around 2 kilograms in weight in the last 2 months. No rash, neurological and cardiovascular, normal initial blood sperm IgG, raised CRP, and a positive rheumatoid factor. Right.
So what's going through your head at the moment in terms of a diagnosis?
Okay, so she's quite young. Symmetrical MCP, arthralgia.
Yeah.
Constitutional symptoms.
Yeah.
So I don't think she has osteoarthritis in her hands, so that's probably rules out number 1.
Absolutely.
No, not joint aspiration either.
Yeah.
I don't think she has kidney disease. That would be more like maybe like a lupus nephritis, number 2.
Yep.
Yeah.
Yeah, I think I go with positive anti-CCP.
Absolutely.
Yeah, that's what it is.
So, yeah, the point of this question is to illustrate like any like chronic inflammatory condition can cause you weight loss, and 2 kg in 2 months is, I guess, is kind of significant.
Yeah, I'd say so.
Yeah. So
if you haven't been trying.
Yeah, exactly. Lupus isn't the only condition that inflammatory condition that causes weight loss. All of these can, to be honest.
Yeah.
Fine. Right. Who can we pick on next? Right. Who's Ankit in the chat? Who's been trolling a little? I'm picking on Ankit in the chat unless he's got no microphone, which is going to be ironic, isn't it? Never mind then. Can you type the letter A if you want to answer this question? If you're still here.
Or just type the number for the right answer if you want.
Yeah, if you don't want to explain your decision. Great.
Thank you. Wonderful.
So I'm a snake, so I'm going to ask you to explain your decisions anyway.
Unlucky, guys.
Prina, why is it number 3?
Can you hear me?
Yep.
I can hear you.
So she's got like a headache and a fever. She's basically got like all the signs of giant cell arthritis, plus a bit of like polymyalgia rheumatica. Like the sort of weakness. So you want to sort of like, because it's most appropriate, you want to give her the steroids and the visual field assessment, and then do all the like other bits later. So like you would maybe refer her to rheumatology and review her again, but like currently you want to give her the steroids and do a visual field assessment.
100%, yeah, exactly. This is not one that you can just rule out. This is one that you just know or you don't know. But to be fair, giant cell arteritis is one of those things you should know. Fine. Next one. Which of the following X-ray findings most specifically indicates the presence of osteoarthritis? So which of these findings is most specific? So just type an answer, sorry for this one.
Nice.
Yeah, exactly. Number 2 is the most specific finding. And unlucky Bruno, but yeah, you can get loss of joint space in other conditions as well.
Yeah.
Right. So there's one more SBA, but like we do need to do one thing before we get onto that. So
you know what
this is the first online lecture we've done. And the reason it's been a bit itty bitty is because me and Ahmed have been lumped with doing the trial run. So if you think it is, so I put a link in the chat. If it's useful, fill that out, please. And then I'll just start in like 2 minutes. God, they haven't updated the feedback form. Just pick term, just pick other for date session. Like, please fill it out because otherwise, like, we can't run more of these.
Yeah.
Was this PowerPoint exactly the same as the MedSoc one? It's almost the same. The MedSoc one has more information on it. We just thought it wasn't that easy to teach over like online.
We kept the most important bits.
Yeah. Also, we thought that like if we did it like the MedSoc lecture online, it would have ended up being like 3 hours long.
Yeah.
Does anyone have any questions about Module B that we haven't answered? I shall. So the questions you've answered while going along, some of them are on the PowerPoint. Yes. I think most of them should actually be on the PowerPoint.
Yeah.
The other thing is, if any of your friends have missed this lecture, I've actually just recorded it. So you should be able to look through it in your own time. Obviously less than ideal, but yeah, have a look through the MedSoc PowerPoint. I'll put this PowerPoint up as well. Again,
Yeah.
I posted it a few times. Which condition is onion skin periosteal reaction seen in?
Why doesn't somebody else tell us?
Does anyone else know the answer to that?
Yeah.
Just ignore it. It is a bone cancer. Do you know which one? Yes, you're in sarcoma.
Nice one.
Yeah. That's like, if you see that in an SBA, the answer is always Ewing sarcoma.
Yeah.
Fine. Yeah. Yeah, write others and type our names in for tutors.
I don't think you'll ever see
Also
it.
comment. Also, can you like also comment on like how like the online stuff is?
Yeah.
We don't like, it's really hard to like do interaction that isn't awkward, like, because it's kind of hard, to be honest.
If anyone has ideas for how we could make the interactive bit better,
that's like stuff we want feedback on.
Yeah.
Maybe polls. That's a good shout. Yeah,
that's a good shout. Yeah.
Also, if you want, so the plan is a lot of the other revision lectures will be moved online over the next few weeks. But yeah, if any of you want like smaller group teaching, me and Ahmed will probably be happy to do that because we have nothing else to do with that.
Yeah,
time.
literally.
So yeah, drop us a message. Yeah, drop either of us a message and we'll sort that out for you. Fine. We're going to go on to the last one. Subchondral cyst. I'm going to pick on one other person. Sean Lott. Do you have a microphone and can you answer this one? No, Mike, right. It's fine. Answer it anyway. Even though someone has already answered it, to be fair. So I'll just take that as the answer and move on. But yeah, this lady has had a tuberculosis skin test. So the tuberculin skin test isn't really used anymore. Just a heads up. They do like an IGRA, unless those are the same thing, but I think they are different things. So she's been treated for her latent TB, and she's got pretty much really non-specific symptoms, and antihistone antibodies is the giveaway. In an exam, they would always tell you about antihistone antibodies if it's drug-induced lupus, so don't worry about it. But, and yeah, isoniazid is the only one of these drugs that's really associated with drug-induced lupus. Before you all head off, should we talk quickly about the side effects of the rest of these drugs? Does anyone know what rifampicin will cause the biggest side effect? Orange secretions, yes.
Yes.
Cool.
What? Just to clarify, liver. What does it do with the cytochrome system? Inducer or inhibitor? Because that's really important.
Yeah. It does also cause hepatitis, by the way.
Yeah. Good. Yeah. So inducer. So remember, all the other anti-tuberculous agents are inhibitors. That's the only one that's an inducer. But yeah, very nice.
We've spoken a bit about isoniazid, but there's another really important side effect for like a quality of life thing. Does anyone know what that is? So think peripheries. Yep, peripheral neuropathy. Do you know what you can give to treat that peripheral neuropathy? Yes. Oh, I love it when people preempt my questions. Pyridoxine, which is vitamin B6.
B6,
fine.
wonderful.
And ethambutol. Yeah, eyes again.
Yeah.
It's like similar to
hydroxychloroquine.
It's similar to hydroxychloroquine actually. Yeah, you get like red. I think it's loss of color vision is the first thing.
Yeah.
So like with ethambutol, it's interesting. You only usually use it for 2 months. After 2 months, if you have to use it for a longer period of time, then you're really worried about the eyes, because in the first 2 months it's usually okay, but you still monitor it. Yeah. Fine. All right, that's us done. If you have any questions, we'll stay online for like another 5 minutes maybe.
Yeah.
So just drop them in the chat. Also, if anyone has more specific feedback, drop us a message. We're kind of interested as to like, we also want to know if you want more SBAs or we'd rather just ask you questions as you go along.
Yeah.
Because it's easier for us to do that. Yeah, no worries, guys.
No worries. And yeah, like Anush said, if anybody, they should be on the MedSoc. They'll come up on the MedSoc Education Facebook page.
Yeah, the revision lectures will come up on there. If you want, if you want other stuff though, we can try and organize that. Let us know that.
Literally, please give us something to do.
Yeah, we're bored.
Please give me something medical. Don't give me something surgical, as you probably saw from today. But
how do we get the recording? I will find out and I will post on the MedSoc page about how we can get the lecture. Yeah.
No worries.
Right, we shall wait until this room empties out.
Yeah. Yes, Amna, what's up? No worries, Alexis.
Yeah, that's not a bad show.
That's not a bad idea.
Because...
Good night, Alexis. Hope you get some sleep.
So in an acute presentation, gout and pseudogout will present identically. The differentiation comes from the joint aspirate and or the location of the joint.
Yeah.
So if you've got like a knee, it's much more likely to be pseudogout rather than gout. But then if you've got like the first metatarsal of the toe, then it's more likely to be gout. Also, like, if you're still here, just remember, like, not for your exams, but in clinical practice, there are more causes of an acute monoarthritis than just those 3 things. Sarcoid can cause it, tuberculosis can cause it, all of these things can cause it. It's just, for your exams, the 3 most important ones are septic, arthritis, gout, and pseudo-gout.
Yeah.
No worries.
No worries.
I can't wait to read all this exciting feedback.
No worries, guys. Yeah, no, we love rheumatology, but ortho.
Rheumatology is everything good about medicine in specialty, except for osteoarthritis.
And osteoporosis.
Oh God, osteoporosis.
Oh, yeah.
Learn the guidelines, guys, please. They're on the slides. Any other questions? No. How many people are still on this thing?
10 of us, not including us.
No. All right, lads.
Thanks for dropping in, Ankit.
You know, he actually had his iPad out and was doing revision, apparently.
Wait, is Ankit 6th year?
No.
Or 4th year? Because there is an
R-
Ankit in the year above us, isn't it? Oh, Ankit's an R year. Wait! This was Sinha.
Yeah.
You motherfucker!
Oh, lovely. It's going to be on the recording.
Oh, okay. I almost followed that up with a. You can chip off the recording. That's fine.
Yeah, I'll just.
Oh God, I can't swear at him. This is really distressing for me.
Anyone else have any other questions?
Half of my vocabulary. Oh, is Amna wanting to come back in? Let's admit her just in case.
Did you have another question? What do you think will happen to exams? I mean, I could say whatever the hell I wanted, but none of it really matters.
I think likelihood realistically is modified OSCE and online SBA, I think, is probably the most likely thing. I don't think this is going to peter out by then.
Yeah, I would still heavily suggest that you continue preparing as you would otherwise.
Yeah, exactly, yeah.
Before they announce anything, though, like, don't be like, oh, there's not going to be an OSCE, and don't do any like try and still do your communication stuff over Skype if you can practice things
Use
like
your
that.
quarantined family members or flatmates for examination skills.
Yeah, we don't know anything. We know as much as you do.
Yeah, we are in the same boat, alas.
No worries.
No worries.
Who else is still in this room? Ankit is now leaving.
Ankit's gone. Okay. I did not know that was our year's Ankit. I thought that was like one of the finalists.
Yeah.
Never mind.
Right. The main people in the school are Mariam, Alexis, Arushi. Guys, can we help you with anything in particular? Should we? Is this Mariam in our year? Mariam, is this you?
Ah. Huh.
As in, she's on the MedTalk subcommittee.
Oh no, I mean, we're happy to have you back, Alexis.
Yeah. It's also just we kind of want to eat dinner, maybe.
Oh yeah, I forgot about that. It's also a nice time to go for a run because nobody's outside. Therefore, I don't have to worry about people.
Right. How do I stop recording? I'm going to stop recording.